And good morning and welcome to Hawaii Matters. This is Devin. I am your host for this morning's show. I'd like to welcome into the program Dr. Jay Ishida. He is an emergency medicine physician over at Kaiser Permanente. Good morning, Doc.
Good morning. Thanks for having me.
And actually, this is the second time you're coming back to us. So thank you very much for taking the time to do this.
Well, it's been a pleasure.
Yeah. So last time we kind of talked about Halloween. It was around the Halloween time. So we were worried about kids being safe during Halloween. But this one, it's just in general being safe. My coworkers and I each kind of went through a sickness.
Oh.
And, it just reaches that point where you go, do I go to the doctor? Do I not? Like, when do I need to go to emergency? And I know that the rule of thumb has always been, well, if you're worried, just go. But I think most people want to feel, more confident about it.
Well, that is correct. The rule of thumb is if you're really worried about it, we're open 24/7, and that's what we're here for. You never know. Sometimes it could be really bad. And in general, if you're having chest pains or trouble breathing or feeling like passing out, of course, those are always concerning and good reasons to present to the ER. But, like you said, in your situation, if it's just not getting better, a lot of times if, primary care doctor's offices are really busy and sometimes, they're kind of full. So, we take care of overflow situations like that too. But, that's what we're here for. So
right.
Never, I do have patients that apologize to me, say, I'm sorry, but I'm saying, no, don't apologize. That's what we're here for. That's our job.
You've been doing only emergency?
Yes, I specialize in emergency medicine.
So what does that mean to specialize in emergency care?
So, as of a couple decades now, it's been a board certified specialty where you have to actually go through specialty training after medical school to basically be able to identify and take care of life-threatening emergencies and stabilize people in life-threatening events. And so it is a specialty, and it is required to be board certified. And so it's basically you take an actual internship and residency in this specialty for 3 years afterwards, after medical school.
Now, does this mean that because you're going to see just about everything in the emergency room, does this mean the breadth of your medical knowledge? Do they have to expand that, or is it not only expansion but something else?
So emergency medicine physicians are sort of still generalists per se, where we have to know a little bit about every specialty.
Right.
Whereas, for example, a heart doctor or a cardiologist knows pretty much everything about the heart.
Right.
Correct. Yeah. So, what we know is we have to know the emergencies or the critical conditions for each specialty. So for that reason, I'm sort of a generalist where I have to know a little bit about every specialty that pertains to life-threatening events.
Now, as far as Kaiser Permanente goes, a lot of people have never been to the emergency room. If it is your first time going, can you describe what it's like?
A lot of emergency rooms have several things in common. Of course, we're bound by federal law called EMTALA, where no emergency room can turn anyone away based on insurance or
really?
other factors. Yes. And there's a federal law requiring that you have to provide a medical screening. And so every ER, if your urgent cares or clinics are do not have this applicable to them, but every emergency room, we see everybody who walks in the door regardless. And that's Kaiser, Queens, all the emergency rooms. And so when you get to an emergency room, if you present by car, for example, you will be greeted by a nurse or a tech or specialist that will triage you, will collect your information, and then based on the severity of your illness, you will be brought back into the emergency room. And this is something that's really important for people to understand, because unlike when you stand in line at Costco, I'm the second in line, you are the first in line, you're going to be seen first. That may not be applicable in an emergency room if I've been waiting for 2 hours with, a cough or a sprained ankle, and you come in with, for example, a life-threatening event.
With bones sticking out or something.
Correct.
Right.
then we're going to whisk you back first. And that's just because we have to triage the severity of illnesses first.
when you're on duty, how many different emergency doctors are there with you?
Well, it depends on the emergency room. Some emergency rooms see a lot more patients than others. Some smaller emergency rooms, the neighbor islands, or will only have one. Whereas some busier ERs have several, and it depends on the time of the day. In the middle of the night, the amount of patients tends to decrease, except for Friday and Saturday nights. But
tell us about that a little bit. Like you were saying, I mean, it goes in waves. So morning, if you're gonna get hurt, morning is better than late at night. Or
well, as you can imagine, the Friday nights and the Saturday nights, we always have the consequences of intoxication, etc., and all that. And typically, Mondays tend to be a little bit busier. Over the weekend, the doctor's offices are maxed out. People have been busy over the weekend, and the doctor's offices aren't open always. So Mondays tend to be busy, but overall, in general, it's really hard to predict how busy it's going to be in the ER. You can sort of guesstimate, or it's always variable. It always catches you off guard sometimes.
And how many times are you confronted with these really major ones? Because it seems like, I've been to the emergency room once, maybe twice, and most of the people sitting there look like they have colds or something. You know what I mean? So it's almost a thing of they're sitting there like, I don't know what to do, so we just came to the hospital because they're telling us to come to the hospital. But there must be these serious ones that come in and you go, whoa,
Yes, like I said, it's sometimes feast or famine, or it's just good or bad. You never want someone to be really sick. It can go from 0 to 60 in a blink of an eye, and it's really unpredictable. And we always like to see less of it, of course, because that means people aren't getting into bad accidents or having critical events. But it's really, really variable. And, it's when you're sitting in the waiting room and the people sitting near you, they're sitting out there because a lot of times they, have less life-threatening vital signs or screening. I'm not saying that you're not going to have anything out there, but the triage nurses are trained to identify abnormal vital signs, etc.
Right, and that's the thing I think people need to understand is that it's not that they haven't even looked at you and don't recognize that there's an issue. They just, like you were saying, they triage it and go, okay, this one can wait, this one needs to go now. It's sort of like, it kind of reminds me of watching MASH.
That's absolutely correct. If someone's blood pressure is very low or their breathing is not very good, they won't be sitting by you in the waiting room. They'll be brought back, and we will have to institute resuscitative measures for that. Yeah.
One of the things I kind of wanted to get into is sprains versus breaks. We had I'm in a show, and one of the young girls who's a dancer, she came up, landed on her foot, and she was just in extreme pain, just crying and stuff. And it's a little kid. You're thinking, how bad can it be? She probably just sprained her ankle a little bit. No, that's not what happened. Ooh. She actually had broken her toe. But it was hard to tell. She just looked like she was in pain. Mm-hmm. So I guess that's my thing. Like, is there a way to tell the difference? Is there something to look for?
Well, I hope the dancer did well. I'm sure she did. I'm sorry to hear that she got injured. It's very difficult to tell for certainty without X-rays if there's a sprain or strain. And there are some clinical guidelines that we use as physicians to see if patients, have a high risk, which would warrant X-rays. And so, one of the layperson's sort of criteria might be if you can't walk on it, if you, for example, injure your right ankle and you can't walk on it for several steps, it's more likely to be a break. Now, of course, people have what's called different pain threshold levels.
Right.
So, if I can't walk on it, it still might be sprained. Whereas, if a really tough guy, he can walk on it, he still might be able to walk on a broken ankle.
That would be my father-in-law.
Yeah.
But yeah.
So, but that's just a general rule of thumb. If someone can't walk on it, then be more concerned. Or if the pain lasts for a prolonged period. Sprains, of course, will get better within a day or 2, 3. But after, I wouldn't wait more than a day or two before, if you're having significant pain, before you check it out.
Would discoloration make any difference?
Definitely, it definitely does. A lot of times if you have a fracture, it'll be more likely to be bruised and black and blue. However, I've been fooled in the past. I've seen injuries that are all black and blue, and we got several x-rays and
nothing.
Nothing. So, but if it is black and blue and swollen, then that it increases the chance it might be something broken.
Okay, well, here's another question. Kind of sparking off of that. Oh, and by the way, sorry, Hawaii Matters. We're speaking with Dr. Jay Ishida. He's the emergency medicine physician over at Kaiser Permanente. It's nice to have him back with us today. We're talking about when do you go, when do you not go. One of the other things was if you break your toe, some people say, I know it's broken, I don't have to go, because they're just going to tell me they're not going to do anything anyway, which I know is wrong because you're laughing. But how do you explain to somebody about that? Because sometimes they think, well, it might be broken. I'll just wait the 3 or 4 days till I get to see my regular doctor instead of taking care of it now.
Mm-hmm. So fractures can be addressed in a you do have some time to address the fracture, as long as it's not sticking out, and as long as there's no, the bone's not sticking out. The treatments for certain types of broken toes sometimes are what's called non-operative, means you don't need surgery for it. But if you want the best chance for having your foot working normally in the future, then you probably should get it checked out. Now, if you say, you see, I may not be an athlete. I'm not a professional athlete, but, we take it for granted that we can walk without pain every day when we go to work, go to the store, go to whatever. So, it's best to get it checked out, because in case you need a certain type of treatment to ensure that your foot functions normally with the least amount of pain in the foreseeable future, that's the reason why you should get medical treatment, because it is possible. It may be non-operative, so to speak. However, even as an emergency physician, I still refer to the specialist, and they make that decision. So,
okay.
Yeah. So a lot of times, it's you want to make sure that your feet and hands, retain their capacity, and you can use your hands and your feet, for the rest of your life in the best capacity. So that's probably the best way to check it out.
Very good. Okay, now we'll move up the body, get to the heads. My coworker, she was asking about head injuries. A lot of kids playing football, or just walking around. Kids are clumsy, right? And they fall and they hit their head, and then there's a question of when do you take them? How do you check for concussions?
Well, it's fortunate that the athletic community is more vigilant about being aware of concussions, especially in the sports arena. All the sports now, the trainers and the staff are being better educated in identifying this. And so a lot of times if you have an injury on the field or during practice, then you have someone there. If someone's at home and Johnny falls off his bicycle or something, then you don't have anybody else there. Things to be concerned about with a head injury is if there's loss of consciousness. So if you black out, if a child or a person blacks out, if after the injury they start vomiting a lot, okay, or if they start having, of course, seizures. Most people would call an ambulance if somebody has a seizure, but if you have a head injury and something that you're concerned might be a seizure, some seizures are not that obvious, and you think that there may be a seizure, then those are reasons to activate 911 or bring someone in. And other red flags would be blood coming out from the ears, of course, or the nose. And these are certain types of fractures that, a lot of times if somebody has blood coming from the ear after the head injury, they would come in. But those are indicative of certain types of fractures or injuries.
Now, if it's not that serious, if they're just feeling a little dizzy, if they're not quite right, bright lights and stuff like that, would that be another reason to bring them as well? I mean, how much time do you have? I mean, if
usually we observe or recommend close observation for about 4 to 6 hours, and it really depends on the mechanism, which is how the person got injured. And so this is not a hard and fast rule. It depends on the situation, of course. But concussions, there's no scan or X-ray or pretty imaging test to diagnose a concussion. The concussion is based on a blow to the head, a strike to the head, along with presenting symptoms. So, a headache, dizziness, like you said, after a head injury, that constitutes a mild concussion. And we're identifying this more and more. It just wasn't identified back in the day when we all played football.
So shake it off and get back in. Go play or something, right?
Yeah. So, if you don't have a lot of those red flag symptoms, and Johnny's doing okay and seeming like he's doing all right, and Johnny's not vomiting, he may be a little tired, but he's not, really acting different, then it would be prudent to, just keep a close eye on him. But if you're concerned at all, this is, like I said, this is what we're here for.
Yeah, just bring him in.
Yeah.
Okay.
Yeah.
One other thing that came to mind, stitches. Every kid has done something where they bang their head, they cut their foot, even for us, right?
Yeah.
But there's always this, it seems like there's this fine line of when do you go and take them in to get stitches, and when do you just go, we'll get a Band-Aid and put that on and it'll be fine. Is there a hard and fast rule for that?
Well, there is actually a recommendation as to the time window that we have for safe closure of a wound, because the longer the wound is left open without proper cleaning, the increased chance of bacteria building up. So if you're concerned that your wound might need stitches, don't wait overnight and go the next morning. You should get it checked within several hours.
Well, is there a depth or a length of the cut that you need to worry about?
Yeah, that's a good question. If you see adipose tissue, basically it looks like yellow or white tissue underneath the skin.
Oh, that sounds so gross.
Then yeah. So if you have that reaction, come in.
So that tissue just means that it's a much deeper cut.
It's through the skin, correct? Yes. Sometimes there's so much blood you can't see it, and
Right.
so of course if it's bleeding and you won't stop, then that's another reason people come in, because they can't. It just keeps bleeding. And of course, some people who are on blood thinners, for companies, those they have a hard time stopping the bleeding too. So that's another reason. Even though they not needing these stitches, they may have a hard time getting the bleeding stopped. So that's another reason to come in, if people are on blood thinners for various medical reasons.
So I'm sorry, I got to back up for a second. So what is that sort of that time frame that people need to keep aware of as far as bringing in somebody for stitches?
Given the fact that some ERs are pretty busy.
I know it depends on depth and all that stuff.
It probably, I would say about 6 to 8 hours.
Okay.
And certain places like the face and all that, it's a little variable, but get it checked out within 6 to 8 hours, because sometimes people will present with a cut, laceration that occurred yesterday, and it would have needed stitches, but we'd have to do other means, delayed secondary.
Okay, wait. Back up. Tell me about this.
Yeah. Well, first of all, if you have any type of laceration or wound, you would apply pressure with a clean dressing or clean paper towel gauze. Apply pressure to stop the bleeding. Then I would recommend washing it out, with medical antiseptic or anything like that. Washing it and cleaning it. Now, if it's open and you have the reaction, oh, that's gross, there's a whole bunch of stuff, then you need to get it checked out. Now, if the bleeding seems to be stopped, and if it's less than an inch or very small, then you might be able to watch it for a few hours. But in certain situations, we've had people come in the next day, and it could have used some stitches, but it's sort of too late to close it.
It's already started to heal?
It started to heal, and so, or sometimes there's an infection starting, and so we have to start treating that. And so that's another reason why we have ways to clean it out. There's recommended ways to irrigate.
Are there ways to clean it out that it doesn't hurt? Because that's the one that I mostly worry about, is that I come in and I say, hey, Dr. Ishida, I have this cut. It's really bad. Can you clean it without it hurting at all?
Well, there are numbing medicines we can put topically on. Sometimes you have to inject medicines, which do hurt a little bit. Mm-hmm. But we do use, sterile solutions to irrigate and flush it out. And you can get similar type of solutions at the drugstore to wash it. But
okay.
I would recommend washing it as best as you can.
Yeah. Now, does the length of time between having the cut and getting it stitched or whatever matter at all with regards to scarring? Because that was one of the, I don't know if it's an old wives' tale or what, but right, they would always tell you, well, you have to get stitches, otherwise you're going to get a big scar.
That is a wives' tale that's kind of correct, because in the situations that we aforementioned, we can't close it. We can't do the stitches because it's been a day, and so we'd have to wash it out, clean it out, and we have a discussion with the patient as to the risks and benefits, of course. But if you don't stitch it, the scar tends to be bigger. Okay. Now, the stitching essentially obtains two objectives. One is to stop the bleeding or slow the bleeding, and to minimize the scarring. And so that's correct. If if you don't care about how big the scar is, and it's not bleeding, and you cleaned it out really well, then if you cleaned it out adequately, and it's not bleeding, and you don't care about the scar, then you really, it's arguable if you really need stitches in there.
Because some women like scars.
Yeah.
Or guys.
Yeah.
Whatever.
That's tough.
So,
yeah. But you got to clean it really well. So that's the key. It's you got to make sure it's really cleaned out. So there's risk of infection is very very low. Yeah.
Okay. This is Devin with Hawaii Matters. We are sitting with Dr. Jay Ishida. He's an emergency medicine physician with Kaiser Permanente. Nice to have him back joining us to talk about emergency medicine specifically. We talked about cuts. We talked about concussions. We talked about broken bones. Also like to talk about fevers when you have a little one, or even when you have older people. The elderly, you deal with fevers a lot, you deal with colds a lot, and there is a question of what to do.
So fevers, the recommendation for fevers vary based on age, of course. And, starting from the newborns, children from, 0 to 3 months, especially newborns less than 28 days or less than 1 month, there's specific recommendations as to what happens if you have a fever. And, this is because the newborns are more susceptible to infections, both that can be acquired, in the community like you and I would be, or through the birth process. And, their immune systems may not be up to par. So if your newborn is less than 28 days and has a rectal temperature over 100.3, so 100.4 or higher, and this is based on the Celsius level, that's why it's a weird 100.4, it comes out to 38 Celsius, then there's certain types of tests that needs to be done. If your child is older than 3 months, then it changes, and it depends on the immunization status. Generally, if you're immunized and your fever is, less than 102.2, basically 101, and it's for a couple days, and the child is acting pretty normally, hydrating well, not vomiting, and kind of, hunky-dory and carrying on, then for a couple days, it's usually okay. After about 4 to 5 days, usually you should start seeking advice, especially earlier if the child is not acting right, if you're concerned in any way. That's kind of a general rule of thumb.
Yeah, they talk about lethargy in children as well, right? If they're just they don't have interest in stuff, if they just sort of lay around.
Yeah. Now, it's important to get them treated with Motrin or ibuprofen or acetaminophen, of course, if there's no allergies, because a lot of times, like you and I, when we get a fever, we don't feel like doing the dishes or doing anything. So the child is the same way. They don't want to play. They have a fever. They feel crummy. So if you give them an antipyretic like Tylenol or Motrin, assuming they don't have any allergies, they usually perk up, and then you can get them to eat and drink, and you can get some fluids in them. So it's really important to, use that strategy, at least for the short term. So lethargy is when they're really lethargic. An ER doctor means despite the Motrin and the Tylenol, they're still just not really cutting it. And that's a big red flag, because usually with simple colds and things like that, you give them some ibuprofen or Tylenol or acetaminophen, and they'll perk up enough we can get some fluids in them, and they'll eat. So,
Okay. Yeah. Now, one of the other ones, I wanted to go in the other direction age-wise, because we have a much larger older population, elderly population, and we've had these colds and flus that are ripping around, and it hits them hard.
Yeah.
So, is there something that you need to look for with regard? I mean, is it the same thing where you look for the fever, you look for lethargic, that kind of stuff?
It's a good question, and it's a lot of times they're kind of similar. The big difference is that
they're also worse patients because they're adults and they don't want to go, and you can't make them go, right? So they go, no,
it's your dad or your mom, and you're like, no, Dad, you gotta go in. You're right. That's true. That's totally true. So the big difference with the geriatric patients is that sometimes they don't mount that of an oppressive or that high of a fever. Okay, so they're the opposite spectrum, where sometimes their immune system is not as robust as a 20-year-old's. So sometimes they'll present with things like lethargy or confusion. Grandma might just be acting funny, quote unquote. She may have a low-grade fever of maybe 99 or 100, but she'll be acting funny. Or they'll have generalized weakness, where they normally walk around with a walker, but now they just can't really get out of bed. They're too tired and weak. So those constellation of symptoms would be concerning for maybe an infection going on. Of course, if mom can't walk, then a lot of times they'll be bringing them in. But the difference between the geriatric patients and general adults is that they may not have a big fever. They may have lethargy. Like
is that because they're older and so the body isn't used to raising the temperature?
Yeah, a lot of times the immune system's response isn't as pronounced or as robust as 20-year-old, 30-year-olds.
That's interesting. One of the other things that's been interesting is I caught a cold myself recently. I think everybody's been catching this cold. It's awful. But my doctor, when I went to see him, he said, you're here too early because we can't really tell which one it is. He said that nowadays, this new one that's been coming out, it's sort of taking two tracks. One is a more bacterial line, and the other one is sort of a virus. And I wonder if you could explain the difference to people, because if you're getting a bacterial one where it's bronchitis, where it's pneumonia, you definitely have to go to the ER and get yourself checked out. Yeah. Whereas the virus one or the viral one, you kind of you deal with it and you go through it. But are there things that you need to look for?
So the longer condition lasts, the more likely it might be a bacterial process. There are conditions where it starts off as a virus. For example, the classic one would be get an influenza, which is a virus. It's not a bacteria, so you don't need antibiotics for influenza. But certain times after the influenza, in rare situations, you can have a bacteria move in and secondarily start an infection in the lung, and you can get a secondary bacterial infection. But that usually that's about after a week or so of symptoms. Then you're just not getting better, and so that's another reason why after especially a week of symptoms, you definitely probably should get some medical evaluation, because things should be improving. If it's just a virus, it should be getting better within 4 to 7 days. But if it's lasting more than a week, you should definitely get that evaluated.
Oh, wow.
Yeah.
And is there a way to tell the difference between if somebody has bronchitis, which is bad, and if somebody has pneumonia? Because it seems like the two are kind of related, but when they split off, the pneumonia gets really bad.
Yes, and it's a spectrum. The bronchitis is on the more mild side of the spectrum, and the pneumonia is, of course, more severe spectrum. And it is kind of our fault as physicians. Is a lot of times some physicians will treat bronchitis with antibiotics. In certain populations, that would be appropriate if you have bad lung disease, etc. But in a general healthy young adult, generally bronchitis isn't always treated with antibiotics. A lot of times bronchitis is viral, but a lot of doctors,
just slam it with drugs.
Well, it's a discussion with the patient. Some patients feel more comfortable with it, and such and such. So it's been. We've been more interactive with our patients, and so sometimes a lot of doctors will give it. Now, pneumonia per se, you usually have findings on physical examinations. So if the doctor listens to your lungs and hears a pneumonia, or sometimes in the ER we do a lot of X-rays. The doctor's office don't do many X-rays because they just don't have X-ray right there. But we have it there, so we just use it, and we'll see a pneumonia on the X-ray.
What does that look like?
It depends. There's various. The classic pneumonia looks sort of like maybe a triangle or wedge or just a shadow. But there's all different types of pneumonia, round pneumonias, etc. But basically, think of it as a shadow on the lungs when you.
And it's an infection that gets into your lung that you need to get out. Correct.
Yes, and those you need antibiotics for. And in certain populations, asthmatics, diabetics who have bad lungs sometimes have to be admitted to the hospital. But a lot of people can be treated as an outpatient for pneumonia.
Yeah. So if someone is presenting to me, or they say, "Oh, I have pneumonia," and they're just sitting at home, they're not doing anything. Is there a point if you see them physically a certain way that you should really take them in now?
Well, if they're having trouble breathing, and looking like they're really weak and winded, then you should definitely get them checked out. Because if left untreated or inappropriately treated, a pneumonia can affect the lungs where you can't breathe and you can't get oxygen into your body. And
that's bad.
Yeah, it's very bad. Yeah.
Okay. Yeah, we want to try to avoid that as much as possible.
It's a true emergency.
Okay. Dr. Ishida, it's always wonderful to have you come by.
Yeah.
I'm sure we were supposed to talk about other stuff too, but our time is almost up, actually, believe it or not. So, in closing, was there anything was sort of in a general way that you wanted to tell people with regards to making that decision of ER or not ER?
Well, yeah, like you said at the very beginning, that's what we're here for. We're here 24/7 to check you out if you're concerned at all. Because the last thing you want to do is be concerned about it, put it off, and it turns out to be something extremely bad, and you have something extremely bad happen to you. So, when in doubt, definitely check it out. And I hope that some of the advice we gave here today might help you with that decision. But we're open 24/7, and that's what we're here for.
Awesome. Thank you so much, Dr. Ishida. Oh, before you go, real quick, signs of stroke and what to look for.
Oh, that's right. So stroke is a time-sensitive condition.
Right, exactly.
There are certain medications or interventions that need to be given within a certain amount of minutes to hours within onset of symptoms. So if you think you're having a stroke, you need to get over immediately. So signs of stroke that would be concerning: slurred speech, drooping of one side of the face. So if one side of your face looks like a wax figure and is just melting, or one side of your body being weak. So I don't know if you remember Kaiser, the guy with the red side and the blue side.
Right.
Yeah. So one side of your body would be weak. And so if your arm's weak and you're dropping your keys and you're slurring your speech, you should call 911. The paramedics know which hospitals, are specialized in treating strokes and things like that. And
also, there are specialized things.
Well, a lot of the hospitals are nowadays, but certain facilities have different capacities to treat, to treat certain conditions. And so, if you're in doubt, definitely check that out.
And that's also use the acronym FAST, right?
FAST, yes.
Yay, I remember. See, you taught me some stuff. All right. Dr. Ishida, once again, thank you so much for stopping by. I really appreciate it. He is an emergency medicine physician with Kaiser Permanente. If you do need more information on all of the stuff that we talked about, you can just go to kp.org. This has been Devin Nicoba. Thank you so much for being with me, Dr. Ishida.
Thank you for having me. It's a pleasure.
And till we see you next week, thank you for joining us on Hawaii Matters. Aloha.